Normocytic anemias with predominant intravascular hemolysis, proximal nocturnal hemoglobinuria, acquired defect in myeloid stem cells resulting in absent glycosyl phosphatidylinositol, rendered cells susceptible to destruction by complement. Blood cells coexist with complement. Decay accelerating factor on the surface of blood cells protects against complement mediated damage by inhibiting C3 convertase. DAF is secured to the cell membrane by GPI, an anchoring protein. Absence of GPI leads to absence of DAF, rendering cells susceptible to complement mediated damage. Intravascular hemolysis occurs episodically, often at night during sleep. Mild respiratory acidosis develops with shallow breathing during sleep and activates complement. RBCs, WBCs, and platelets are lysed. Intravascular hemolysis leads to hemoglobinemia and hemoglobinuria, especially in the morning. Hemosideruria is seen days after hemolysis. Sucrose test is used to screen for disease. Confirmatory test is the acidified serum test or flow cytometry to detect lack of CD55 DF on blood cells. Main cause of death is thrombosis of the hepatic portal or cerebral vein. Destroyed platelets release cytoplasmic content into circulation, inducing thrombosis. Complications include iron deficiency anemia due to chronic loss of hemoglobin in the urine and acute myeloid leukemia AML, which develops in 10% of patients. Glucose 6 phosphate dehydrogenase deficiency. X-linked recessive disorder resulting in reduced half-life of G6PD renders cells susceptible to oxidative stress. RBCs are normally exposed to oxidative stress, in particular H2O2. Glutathione, an antioxidant, neutralizes H2O2 but becomes oxidized in the process. NADPH, a byproduct of G6PD, is needed to regenerate reduced glutathione. Le- decrease G6PD, decrease NADPH, decrease reduced glutathione, oxidative injury by H2O2, intravascular hemolysis. G6PD deficiency has two major variants. African variant, mildly reduced half-life of G6PD leading to mild intravascular hemolysis with oxidative stress. Mediterranean variant, markedly reduced half-life of G6PD leading to marked intravascular hemolysis with oxidative stress. High carrier frequency in both populations is likely due to protective role against falciparum malaria. Oxidative stress precipitates HP as hence bodies. Cause of oxidative stress includes infections, drugs, for example, primacoin, sulfa drugs, and dapsone, and fevabins. Hence bodies are removed from RBCs by splenic macrophages, resulting in bite cells, leads to predominantly intravascular hemolysis, presents with hemoglobinuria and back pain hours after exposure to oxidative stress. Hence preparations is used to screen for disease. Precipitated hemoglobin can only be seen with a special Hence strain. Enzyme study confirmed deficiency performed week after hemolytic episode resolves. Number 3. Immune hemolytic anemia. Antibody mediated IgG or IgM destruction of RBCs. IgG mediated disease usually involves extravascular hemolysis. IgG binds RBCs in the relatively warm temperature of the central body, warm agglutinin, membrane of antibody-coated RBCs is consumed by splenic macrophages, resulting in spherocytes. Associated with SLE, most common cause, CLL and certain drugs, classically penicillin and cephalosporins. Drugs may attach to RBC membrane, for example penicillin, with subsequent binding of antibody to drug membrane complex. Drug may induce production of autoantibodies, for example alpha-methyl dopa, that binds self-antigens on RBCs. Treatment involves cessation of the offending drugs, steroids, IVIG, and if necessary, splenectomy. IgM-mediated disease usually involves intravascular hemolysis. IgM binds RBCs and fixes complement in the relatively cold temperature of the extremities, called agglutinin, associated with mycoplasma pneumonia and infectious mononucleosis. Combs test is used to diagnose IHA. Testing can be direct or indirect. Direct Combs test confirms the presence of antibody-coated RBCs. Anti-IgG is added to patient's RBCs. Agglutination occurs if RBCs are already coated with antibody. This is the most important test for IHA. Indirect Combs test confirm the presence of antibodies in patient serum. Anti-IgG and test RBCs are mixed with the patient's serum. Agglutination occurs if serum antibodies are present. Number 4. Microangiopathic hemolytic anemia. Intravascular hemolysis that results from vascular pathology. RBCs are destroyed as they pass through the circulation. Iron deficiency anemia occurs with chronic hemolysis. Occurs with microthrombi, TTP, HUS, DIC, DIC, HELP, HELLP. Prosthetic heart valves and aortic stenosis, microthrombi produce schistocytes on blood smear. Number 5. Malaria. Infection of RBCs and liver with Plasmodium, transmitted by the female Anopheles mosquito. RBCs rupture as a part of the Plasmodium life cycle, resulting in intravascular hemolysis and cyclical fever. P. falciparum daily fever, P. vivax and P. ovale fever every other day. Spleen also consumes some infected RBCs, results in mild extravascular hemolysis with splenomegaly. Anemia due to underproduction. Decreased production of RBCs by bone marrow, characterized by low corrected reticulocyte count. Etiologies include cause of microcytic and macrocytic anemia. Renal failure, decreased production of EPO by peritubular interstitial cells. Damage to bone marrow precursor cells may result in anemia or pancytopenia. Parvovirus B19 infects progenitor red cells and temporarily halts erythropoiesis, leads to significant anemia in the setting of pre-existing marrow stress, for example sickle cell anemia. Treatment is supportive, infection is self-limited. Aplastic anemia. Damage to hematopoietic stem cells resulting in pancytopenia, anemia, thrombocytopenia, and leukopenia with low reticulocyte count. Etiologies include drugs or chemicals, viral infections, and autoimmune damage. Biopsy reveals an empty fatty marrow. Treatment includes cessation of any causative drugs and supportive care with transfusion and marrow stimulating factor, for example erythropoietin, GM-CSF, and GCSF. Immunosuppression may be helpful as more idiopathic cases are due to abnormal T cell activation with release of cytokines, may require bone marrow transplantation as a last resort. Myelopathic process. A pathologic process, for example metastatic cancer that replaces bone marrow, hematopoiesis is impaired resulting in pancytopenia. myeloprotective process.